Welcome again to our podcast episode today of OrthoTutorials. My name is Ezekiel Oburu. I am an orthopedic surgeon at the University of Nairobi, and our topic of today is trigger finger. Trigger finger is also known as stenosing tenosynovitis, and it is one of the most common causes of hand pain and disability. And patients present with pain, stiffness, and a sensation of locking or catching when the digit is either flexed or extended. Trigger finger most commonly affects the ring finger, but the thumb may be involved, and in this case, it is called trigger thumb. All the other fingers may also be involved. Now, what is the cause of trigger finger? It results from a thickening of the flexor tendon sheath within the distal aspect of the thumb. This thickening causes abnormal gliding and locking of the tendon within the tendon sheath. Specifically, the affected tendon is caught at the edge of the A1 pulley. Remember, the fingers have got different pulleys. There is the annular pulleys and the cruciform pulleys. And trigger finger specifically affects the A1 pulley. Now, what's the epidemiology of trigger finger? The incidence is about 2 to 3% of the general population, and about 10% of diabetic population have trigger finger. It is more common in females, especially who are above the age of 50. What are the signs and symptoms of trigger finger? Patients with trigger fingers may present with a number of signs and symptoms, and usually when a medical student hears trigger finger, they assume it's a classical triggering, but there are other signs and symptoms that may actually point to a trigger finger even without necessarily the classical triggering of the fingers. These patients may present with locking and catching during active flexion and extension activities of the fingers. They may just present with a stiff digit, especially if this is long-standing and no previous diagnosis has been made. They may sometimes just present in the early stages with pain over the distal palm. They may actually present with triggering on passive or active extension by the patient. They may also present with tenderness over the A1 pulley, and sometimes you may have a palpable nodule in the line of the flexor digitorum superficialis. So what's the diagnosis of trigger finger? The diagnosis is a clinical diagnosis, and you don't need to do any radiological studies in order to establish this. You may sometimes do a radiological study in order to rule out other abnormal hand pathologies, but this is essentially a clinical diagnosis. So, what are the management options of trigger finger? The management options include conservative and surgical. And in the conservative group, we have corticosteroids. Usually, when I see a patient with trigger finger the first time around, I inject a corticosteroid into the flexor tendon sheath. And most of the time, actually in a very big number, there is resolution of the symptoms. However, in some patients, they may have a recurrence or they may have reduction of the symptoms without completely disappearing. I would give them another shot of a corticosteroid. Some patients do not want injections. They don't like needles. And these patients may have a custom-made splint of the metacarpophalangeal joint. This is not as effective as the steroids, but is certainly an alternative in patients who cannot tolerate steroid injection. Now, if this fails, then we proceed to surgery. And surgery of trigger fingers usually involves release of the A1 pulley. This can be done as a day surgery procedure under local anesthetic. When I was a registrar many years ago, I even did some surgery which involves just a percutaneous release of the pulley in the clinic. But most of the time when I have a patient with trigger finger that's not resolving, I usually take them to the operating theater, and under local anesthetic, I release the A1 pulley. That is the end of our topic today, trigger finger, a relatively simple topic. Thank you very much.